Omdurman Teaching Hospital. Israa graduated from Kassala University in 2013, and she's currently working in a Omdurman Teaching PICU for the last 1 year, and she's the one going to present today the case. Okay, welcome, Israa. Israa, could you hear me? I think you are mute. Israa, could you unmute yourself, please? Israa? Israa, could you hear me?
Yes, I can hear you now.
Perfect. Okay. I'm going to share your screen.
Thank you.
So I just want to remind you, Israa, you've got 15 minutes. I'm going to remind you just for 5 minutes before you talk. Is that okay?
Okay.
Perfect.
Hi. Organizer on Omdurman Teaching Hospital, presenter name Israa Elamin, PICU specialist in Omdurman Teaching Hospital. Next, we will talk about subjective history and relevant information, approach and stabilization, differential diagnosis and more, plan of treatment and course of management, communication with other subspecialties and family, outcome, challenges, reflections and deep debriefing, lesson and learning points. Next. We have a 3-year-old female previously fit and will till found by her mom strangulated with the sweep rope around her neck while she was playing on the swing set in the neighbor's house. The duration of the strangulation is unknown, but she arrived to ER within 15 minutes. No significant past medical history or family history, no previous or social concern. Next. Next.
Yeah, so this is the next slide, Israa.
Okay. On arrival at the local, she was arrested. CPR started immediately. Temperature 35.8. Blood glucose 179 milligram per deciliter. Return of spontaneous circulation at 15 minutes with heart rate 147. Oxygen saturation 100 FI or 200. Non-invasive blood pressure 84/41 at fifth centile. Intubated with size 3.5 cuff tube ET tube and transferred to PICU in another hospital after 10 hours. Next.
Yes, this is the next slide. Hi, Israa. Could you hear me?
I hear you.
Yes, so this is the next slide.
Approach of stabilization after arrival to PICU found hypotensive, blood pressure 59/33 below fifth centile, received 2 pulses of normal saline 40 ml per kg and anthrops start immediately. When line inserted and continue with maintenance fluid extras 5% of staff saline. Regarding the physical examination, just normal air intake bilateral with full of crepitation bilaterally. CNS pupil were bilaterally reactive. 3 millimeter, no conjunctival hemorrhage, marks around the neck, glasgow scale 3 with hypotonia and hyporeflexia on all limbs. Cardiovascular and GIT, no abnormality detected. Laboratory and radiological investigation. Start with laboratory investigation. Full blood count hemoglobin 10.5, microcytic normocytic normochromic anemia with normal total WBCs and low platelet. Renal function test, liver function test, bleeding profile, all of them were normal. Blood culture, urine culture negative. After 15 days, we repeat blood culture and urine culture, show candida. ABG as presentation, pH 7, bicarb 15, PCO2 37 millimole, and PO2 85. Radiological investigation also at presentation, chest X-ray normal at presentation, but after 4 days, patient deteriorated and become hypoxic. We check tube and machine, all of them okay. We repeat also chest X-ray show features of ARDS and treated accordingly. CT brain show hypoxic ischemic encephalopathy with diffuse cerebral edema. Echocardiograph normal heart anatomy with ejection fraction 57%. MRI not done. Plan of treatment and course. Regarding the ventilation, initially been easy to ventilate with the mood pressure support SIMV, setting FiO 200, PEEP 7, PIP 16, respiratory rate 16, ratio 0.8. We repeat the ABG after 6 hours, show pH 7.22, PiCAR 22, PCO 54.9 millimole, PO2 85.9. Later, she, as I asked earlier, when she developed ARDS treated by ventilator adjustment setting. This is the trend of pH and PCO2 from admission till the date of death, as you see in the screen. Start pH 7.2 and PCO2 37. At 30th of June, we then when she developed ARDS, and put it on permissive hypercapnia according to the adjustment of ventilator setting, and show PCO 250 and pH 7.4. On 23 of July, this is the time of we do apnea test, PCO 248, pre-apnea test, and after 98. Regard cardiovascular examination, hypertensive since admission, need inotropes to maybe maximum 15 mic per kg per minute, noradrenaline 0.3 mic per kg per minute. At day 7, we add adrenaline. Blood pressure fluctuating, and we titrate the inotropes according to blood pressure. This is a trend of blood pressure according to that, as you see in the screen. Started with below 5th centile, all of them between 5th and 50s. Sedation and neurology. Sedated by medication, she received midazolam and fentanyl. Neuroprotective management include head in neutral position, normothermia between 36 to 37.5, normal glycemia, random blood glucose 4 hourly, and keep PCO2 45 to 55, permissive hypercapnia, cerebral edema treated by 3% saline normal per kg per hour for 5 days. Brain stem test done. After no convulsion, we do EEG, and all tests of brain stem we done. Also apnea test done at 11:30 a.m. Take 20 minutes. After we finish, we take blood ABG and show PCO 298. After that, DNR is decided on 24th of July. Regarding infection, we treat sepsis according to positive culture, antibiotic, and antifungal were given. Fluid and nutrition, IV fluid is dextrose 5% with half saline maintenance. After 7 days, we start NG feeding, tropic feeding, and increase gradually. We stopped after 5 days from starting the NG feeding due to developed coffee ground secretion. After improvement, after improvement, she regained to NG feeding. Total parental admission not available. Renal and electrolyte disturbance. At day 6, developed acute kidney injury with hypernatremia, serum sodium 193, strength of urine output 1 ml per kg per hour, then 0.5 ml per kg per hour and 0.3 ml per kg per hour. Treated accordingly. We adjust antibiotic, calculations of fluid, urine output, and insensible loss every 4 hours, renal chart, and also developed generalized body swelling with pleural effusion due to low albumin, serum albumin 2 mg per deciliter, and she received albumin and furosemide. After that, she improved. Next. This is a trend of urea as acute kidney injury when she developed at 29th of June, and serum sodium 193. Treatment according to, as I said earlier, 180, then all of them become improved and serum sodium decreased. As I see in endocrine and hematological disorders, at the 9 level of stress hyperglycemia, random blood glucose 500 milligram per deciliter, urine for sugar and acetonol and sugar 2-cross, received insulin 0.1 unit per kg per hour and random blood glucose 2 hourly. Resolved after 5 days and stopped the insulin. Regarding the hematological disorders, low hemoglobin 7.9 transfused, platelet 53, due to sepsis in form of high total WBCs, CR and high CRP, treated by escalating the antibiotic. We take blood culture and urine culture and platelet transfusion. This is the trend of total WBCs, started 11.9 till 2nd of July 20.7 and then decreased after treatment. Also hemoglobin 7.9 transfused after transfusion 11.6 as you see, and also platelet 53, 17, 25, platelet transfusion.
It seems Israa have problems with the net. Hi, hello Israa, could you hear me? Israa? Israa, could you hear me?
Yes.
Oh, okay, that's fine. Yeah, so you're talking about this slide, yeah.
Next.
Okay.
Communication with other subspecialty is a case managed by PICU team, no involvement from other subspecialty. Communication with family, parents were kept updated throughout admission on diary by senior staff, parents updated by the CT brain finding and brain stem test, prognosis and outcome also discussed with her family, and end of life care also discussed with her family. Outcome, unfortunately, she died on the 36th of admission. We face a lot of challenges, like delay in transfer from the local hospital to the PICU, difficult communication with families, stress to medical and nursing staff, lack of psychology support for the family and staff, and ethical and religious challenges. This is the most important. Reflection not done. Lessons, points. Communication is a crucial point of managing such a case between team members with family. Getting a second opinion is quite essential, especially in such case with ethical and religious challenges. Importance of reflection and team debriefing, particularly stressful time, will help in supporting the staff and has an impact on the staff well-being.
Okay, thank you so much, Dr. Israa, about this nice presentation. I think I will gonna leave the discussion and the questions by the end of the session, as I said earlier. And kindly, if you have any questions, just please drop it in the chat and we can address that by the end of the session. Okay. So our next speaker is Dr. Ahmed AbuSebah. I think he's having problems with the internet and he can't log in at the moment. Dr. Ahmed, are you here? So I think he's still having problems to join us here in this session. So
Sorry, Dr. Ahmed has an issue with his connection, so I'm just going to try to find him and then he will join us.
Perfect. Okay, so in this case, we're gonna shift to the next speaker, Dr. Bahaeldin Juma. He's a senior consultant in Ahmed Medical City in Qatar, and he graduated from Al Jazeera University in Sudan, and he had experience more than 20 years in pediatric intensive care and the pediatrics, and he got his fellowship in 2014. He have a huge experience in teaching, and he awarded an excellence teacher for the Ahmed Medical City in pediatric residency program for year 2021. And he's really interested in developing medical investigations, tools, and intervention procedures and clinical researches. And he got a lot of published papers. So we are so happy, Dr. Baha, to have you today. And I hope all the people will enjoy the session and your talk in this session. Hi.
Hello, good afternoon, everyone. I hope my voice is clear now.
Yes, we can hear you now.
Yeah, can you share my slide, Rahab? I sent the email already.
Yeah, not gonna have it. Just give me 1 minute. Could you see my screen now, Dr. Baha?
Yeah.
And everyone, perfect. Okay.
Okay.
So you can start, Dr. Baha.
Greeting for everyone again, and assalamu alaikum wa rahmatullahi wa barakatuh.
Welcome, Dr. Baha. You can start your presentation.
Yeah, it's okay. Actually, it's my great pleasure to share with the pediatric Sudanese Association in UK for this great effort in their KeepMeSafe project. I know the topic is one of the critical kind of topics in our pediatric intensive care medicines, especially when it is related to have a multifactorial that related to such decisions. I'm going to go through my slides. Next, Rehab.
Yeah.
Next one. Yeah. So I think we are going to miss Dr. Ahmed because he's mainly going to discuss the reflection of the difficulties and the challenges of the case which is here by Dr. Israa. So my main talk will be about what the actual meaning of use of don't attempt resuscitation in this case have been presented by Dr. Israa or the others meaning in the ICU. But we have to speak first about the background of some ethics in the critical care medicine. Actually, ethics is all over our medical practice because we have to understand well what is the ethical framework about medical practice. Because as Dr. Israa mentioned in the challenges and relate of the religious and relate of the policies and relate of the law set resources, we have to know that the ethics is drive our behavior, not the law. So ethics came first, and it will be reflect the law as we're going to see. So what are the ethical framework of practice to build up all about such a challenge cases? There is 4 pillars, as we know: the autonomy, the beneficence, and non-beneficence, and the justice. And each of them, they have the meaning. You have to correlate it with what kind of challenge case you pass by it. If we start by the autonomy, this means that you have to respect your patient's right and self-determination. I know this is a bit difficult in our is doing the good and not to doing the bad for our patients. And as the adlin. So as we mentioned that the ethical is, but how the law going to reflect this. Next slide, please. Next slide.
Dr. Baha, we can't hear you. Dr. Baha, are you still with us?
Yeah, I'm here. Actually, all of a sudden it's cut it. I don't know from you or you might actually.
Okay, we can't hear you well now.
Yeah, that's okay. As we mentioned, the 4 pillars of the ethical framework of medical practice is going to be reflected through the laws. And that also you have to put in your mind what the case we hear about it. The autonomy, that means giving you that you have to respect this all interventions procedures which have been done for the patients should be under revision of the beneficiaries is going to be towards the laws by there is no any kind of negligence towards any kind of patients. You are respecting that, you have the rules that you are not doing any kind of criminals, so that you are being going to be under umbrella of any kind of criminal laws while you are practice. And at the same time, justice, this is means by the means of there is no anything that will let you to be under umbrella or under the rules of any kind of undiscrimination law. So when any kind of the cases, and not mean only the critical cases or such a cases in a scenario, we have to respect that our practice should be matches the ethical framework, that at least when you found the challenges, that at least can be reflected by the law under and right way. So the next slide, please. Next slide, Rehab.
Can you see my screen, Dr. Baha?
I saw it, but I think you missed 1 or 2, or this is the right one.
Sorry. So this is the next one.
That's okay. Okay. So as the main objective of this talk is about the don't attempt recitation or the old versions of term as a DNR, we have to look, it's not something that recently have been raised out, but looking for the history is 1970s. This was the start when the thinking that about the issues or the term of end-of-life care or the ethics of the end-of-life care or directive advanced kind of care. It came out when through the nurses actually when they've done that, what exactly the clarification towards such a patients. So since then, started some critical acts or critical end-of-life laws and acts is coming out till the 1970s and 80s. There's start to pop up some of the individuals or scattered kind of laws in different kind of hospitals. And in US by 1909, there is a clear patient self-determination act, which next each countries all of the world they have their own develop its own rules and guidelines of initiation the end of life care. The next slide. So what we mean by the end of life care? The end of life care, the support of people who are in the last months or years of their lives. That means we are not that know the time of their death, rather than we understand their medical problem background. This is going to be an imminent death, which is going to happen in few months or in few days or in few hours. That at least we have to prepare ourselves what's going to be, how much we are going or how we are going to support and such a patients. Next. So when we speak about DNR, and this is very important clarification you have everyone who's in audience in this sessions, is clearly specific when the patient went to the cardiopulmonary arrest. There is no any kind of resuscitation or any kind of interventions going to be done. So don't attempt resuscitation is very specifically for doing cardiopulmonary resuscitations, but it will never change our decision regarding other medically indicated treatment. So all the treatment which is running to the patient who is going to fulfill the criteria to with him under the code status of DNR should be carried patients. Who is going to decide this? The physician decide or the medical DNR treatment decide, but at the time that it should be coming by an appointment, they should be carried to be if patient and choice, but in our pediatric groups, it should be by the legal guardian's acceptance. So who's going to have a right to the resuscitations? If the decision is medically sound and represents the best interest for the patients, as long as they are fully informed regarding the implication of their orders. Just to make not be confused, DNR is specifically for cardiopulmonary resuscitations. It is a medical team decisions, but at the same time, it is a legal guardian's acceptance. So your rules to send the message if the patient is eligible. So what's there in the next slide, please? Next. So if you look for literature and even the titles of this, it's make it easy to say DNR. But recently now, there is a lot of terms is coming out, but the consensus it came in by DNR. So what's the difference between each this word in front of you in the slides between the DNR or DNAR or ANT? All the meaning is end towards not to do a cardiopulmonary resuscitation when the patient went to the cardiopulmonary arrest. But how make this difference between these and abbreviations or mnemonic? It is there. If we say like the old term, what we call it a DNR, this is don't resuscitation. The medical team is not going to do the resuscitations. While if we add the letter A, that means even the attempts of resuscitation is not going to be successfully. But commonly, the term which have been used is the DNR. But now, the current use by European Association of Critical Care and European Association of Resuscitations and Americans of Anesthesia and Cardiology, the term of don't attempt resuscitation, it is the main one have been used. But if we look for the third term, which is an allow natural death, which is abbreviated by an AND, allow natural death is a very open kind of term, especially if you deal with such a patients and you already counseling the family not to do resuscitations and asking you leave it for the natural أو دكتور بتقدروا عليه. That means it's something that an opens, and in medicals and in the critical care medicine, you should be very specifically when you write and you change the code status, which is we cannot write and it doesn't mean that. Shall I admit him to the ICU? Shall I put the tube in? Shall I start any tropes? Shall I put the oxygen? Shall I intubate? It will not be open. So the international term, which is all the association of critical care agree with, is to use the term of don't attempt resuscitation. So it's not an DNR more. Next. This is the same. Next. I hope if I have the monitor to pass my slide. Yeah. So as I mentioned, many institutes now are using the term of don't attempt resuscitations instead of the DNR, which is not going to be an and a word. I hope that when we started in Sudan also, we'll use the updated one. Next. So when we are looking for put our patient under a code status of non-attempt resuscitations, we are in a concept and background making a good death, or there is anything that we can mention it or define it as a good death? Actually, all of us, we want the best care for our patient, and we like the best outcome for them. But at the same, when we speak about end-of-life care, we have to look it from the medical patients or medical point of view, to look what's the best can be done for these patients on background of his primary problem, in background of his support, which he's on already. So a good death, what we are meaning here, that at least to treat the patient as individuals with all respect to his dignities and religious and cultures and background, from financial point of view, from social, from organizational, from psychological point of view. So this is usually, you have to have the vision to look for the patient as universal. You don't look for only in a short window of his medical problems. So in medical problem point of view, making a good death, that making a death without a pain, with symptoms less. And at least I bring all his surrounding here. And when I speak about the surrounding, especially who are practicing outside Sudan, some of them are the families away in the home country. But hopefully that in Sudan, we would like, say, some patients coming from distance, far away from area where he was being treated, he would like to go back, or he would like to bring someone to be beside him. Then in this way, I can minimize the pain. If I'm not going to do the maximum support for this patient, but at least with this categories, with these factors, making him in pain less, making him symptoms less, making him around the people who like to be them, making him send him back to the home country. This is make what we call it good death. Definitely the good death, the death per se, we are not the one we are looking for. We look all the best for our patient as general. Next. So we came to one of the main objective of this text, when and why I need to think about put my patient at the code status of non-attempt resuscitations. When this is when the death is imminent. So in these patients passed by this all around 3 centers, is a swing with unwitnessed hypoxia exposed to him. We don't know how many hours. When he reached already have been clearly have a brain insult, even so that he need to be intubated, then he need to be moved. So what kind of patient this and what outcome this is going to be? So it is very terminal ill, this child when we came in. Is going something that if the brain loss is going to retain this brain back. So there is no any medical benefit expected, with the example which is I'm saying, or there is no any medical we are speaking. If we are speaking about if it is not. Next slide. So there is a medical context that we think about to put them in the DNR. Acutely ill with a background of primary disease who pass by most of the protocols which is supposed to be received. So we reach the prognosis which is almost the death is imminent. Those who are being also taken a chronic illness, which reach to the level they are became an incurable disease.
Assalamu alaikum. Please, the slide is not appear, and even the sound is not clear. So the slide is not appear.
So is anyone have any problem with seeing the slide, or just only you? Guys, could you just put in the chat if you can see the slides or no?
No, there is no slide at all.
We can see.
So I think there is a problem with your internet connection, doctor. Could you just sign out and sign in again, and then you might be able to see the slides. You can continue, Dr. Baha.
Yeah, show me the next slide. Mostly they need to check in again. Yeah, because
is that the slide?
Yeah.
Perfect.
Okay, so we go back again to the when and why. When, if the treating physicians, he should consider don't attempt stations whenever station is determined futile in non-terminal or untreatable disease without known chance of the survival. We do have many kind of situations that can give the reflection that yes, this patient is eligible to be on a code status of don't attempt stations. From here, your knowledge and your background of your patients, it reflects that your decision will be a right decision or no. And most of the time, that's why the don't attempt station or the code status to not state your patients is a teamwork rather than a one physician decision. Those kind of patients, as an example, not an exclusive example, those with advanced stage cancers, those with irreversible multi-organ failures, those with severe brain damage and brain death, as our case of discussion here. If we reach to a baby with an inoperable malformations that incompatible with life, if we have a fatal chromosomal anomalies, or we have irreversible or untreatable and a fatal neuromuscular disease are examples. Next. So, as we know, in the medical teams, especially those kind of patients who came to us in the critical care medicine or the critical care units, we do have barriers towards discussion of the don't attempt station or discussion of end of life care. This is usually making this decision is a big challenges for the critical care physicians if there is no well communications between a team work or the team members in form of the primary treating physicians, especially those who are holding a chronic illness, how they look like, how their course of the disease. And when it came to you in the ICU, it came in a very critical status. You cannot reflect the code status unless you have a good endorsement from your primary physician of these patients. At the same time, if you are not a kind of physician who have been exposed to such scenarios, so you lack the training in making the decision. At the same point, you don't have been trained on such a cases. Then there is again and apart from the barriers which you are going to face it when you are in a situation to decide about the code status of your patients. What's the expectation from the legal guardians? What's the expectation from the family when we speak about the pediatric? What is expectation from the patient if it is an adult case or he have his own autonomy to decide about his case? Or if there is a disagreement about the goals of the care. Say, like I'm a kind of optimistic hematology or oncology patient, and my patient is still in level 3 or level 4 of kind of chemotherapy protocol, and he came with unresponsive shock. You are pushing that my patient from primary leukemia or cancer still, I have something to provide for him, but from point of view of ICU, I couldn't take in anything or let him at least to be in a good hemodynamically stable. So disagreement about the goals, this is one of the barriers also makes the DNR discussions a bit difficult and challenges. Next. Yeah. So your knowledge about the patients, this is the challenge. Your communication skill as a team is a challenge. ethical dilemmas from the religious, from the absence of the policies, from the absence of the rules, from the absence of the local hospitals, ethical committees or ethical departments that can reflect for you how to going to solve these situations, or if there is patience or empowerment or the family empowerment towards making the decisions, or your staff or your team, they have not been trained about such a reflection to about making brave enough to make the decision, or for you on the personal issues. So it's not a matter only of family or policies. Also, as a physicians or a treating physicians, if I have this all subspecialty and transferring the patient to me, they will feel but a bit emphasis or an patience or courage towards those patients who have been treated with them and coming to the clinic of over 10 years and came of this severe critical status to make the decision or give me as a critical physician and a window that you can encourage or discuss with me the end of life care. So it is multifactorial and challenges, including spiritual, including socials, including exceptional, including financials, including psychological, between patients, between the families, and between the treating or primary treating physicians. Next. So this is the domains of qualitative of palliative cares. You have to be exposed for all these domains, at least to be sure you are aware about all these domains, that at least your decision or your selections of your patient to put him in a code status of don't attempt resuscitations, it will be right and it will not be under questionable later on by the legal guardians or by your local role. So you have to have
Sorry to disturb you, just 5 minutes left.
Okay, so we're going next. Okay, so the questions here, how I'm going to communicate with the family to do the, to convince them. I will not say the convince by meaning, rather than to counseling them about don't attempt resuscitations. This is, I will tell not things that to be teach, rather than it should be a process, like a process sequence, starting from the time or where the primary physicians in his clinic, if he will understand and about the background of his patient, that is going to be ended to the level that nothing can be done for the patient. It will be more easy, rather than the patient is came you in a critical situation and you need to make the decision on the spot. So it is process-wise rather than a decision of one times. There is many categories. Next, Rehab, because time. There is many strategies you can build on, but the approach, it will come in a mnemonic which we call prepared. Prepared is a preparation starting by the B. So you have to prepare for the discussions by, I have to know what's the background of these patients, what his medical illness, what his course in his primary disease, then relate to the person that you should approach all those who are in concern of treating these patients. Then you have to select what's the preference from the patient's point of view or from the caregiver or legal guardians in which information they want to start with. Then you have to provide information, means what's the milestone of this disease which the patient passed by it till this level. Then when you address the don't attempt resuscitations ideas, you have always to have to consider the acknowledge the emotions and concern of the families or the legal guardians, and always you have to provide realistic hope. And always you have to be very open windows, not to press on the family to accept your decision about don't attempt resuscitation. And always in such a medical legal issues, you have to document all the scenario, all the setups, with keeping the privacies of this information and keeping the discussion in a well-prepared privacy situations. That means documentation can reflect me the acceptance later on or not. Next. Okay, This is the strategies which is we used to do it here in our HMC for communication skill, and this is a mandatory for all the staff, the joining staff or promoted staff, to be went to the communication skill courses to be teach about the communication. About one of them is about the life end of life care. So how to establish the physician and patients team, then how to share understanding of the patient situation by providing a proper information, and then how to introduce it after you collecting all the data about the patient and then send the message to the family, and how to prepare the family to accept this, and then when the acceptance is there, you should respond with an embassy. While you doing this in a step or process wise, always encourage the express of the feeling, acknowledge their feeling, acknowledge their concern, validate and normalize their concern is not that accepting if already they accept about the status of don't attempt stations. Next, please. So in pediatrics, as you know that when we speak about this end of life care, it will be under the legal representatives, which should be, and from the start in the discussion with the family, you should ask them who is going to be the decision maker for this child. And the stepwise in our policy, starting by the fathers, then the mothers, maternal grandfather, brothers, and who is available, or the eldest one, maternal uncle and paternal male. And this is legal guardians should be decision from the from the family point of view, with agreement for you if the one you speak with this is capable to make the discussion in right way. Next. Okay. So in many times, it's not an easy decision from you as a medical practitioner, or the decision to be accepted from the family wise, and it ends sometimes by unresolved conflict. In unresolved conflict, from point of view, if the patient, there is no times for discussion and patient of eminent going to be cardiopulmonary stations, from the practice, you should go for the cardiopulmonary stations with the time which is approved by your local stations committee. If there is no time that still this conflict is not resolved and the patient is not going enough on cardiopulmonary arrest, this should be referred to the ethical committee if it is there in your hospitals. Next. Next. So if your discussion is ended by the agreement for the don't attempt station as a court status for the patients, our local policy here is the validity, and I think in most of the centers internationally, it will be valid for the acute patients for the 3 months, as long as he's not discharged or he went to the cardiac arrest. For those patients on long term and in long ventilatory support, the validity of the DNR order, it can be up to 1 year from the time when initiated. So for the acute illness with a terminal illness, if this form or this code status will be valid up to 3 months. For those who are holding ventilatory support, or what we call it a long residence patients, this can be valid up to the 12 months. After these two durations, you need to reassess your code status by the same scenario, getting back to the information about the patients, what support have been given to the patient, and rediscuss it with the patient to revalidate your orders. Next.
Time finished.
Okay. I think I'm done already in 2 or 3 slides. This is actually one of the and a wisdom word have been said. There may not be anything left to do medically, but there is always something left to do for your patients. So as long as your patient is already fulfilled the criteria of the don't attempt stations, the others medical support should be carried on. And this is very important. In which way? When the family feels that because their acceptance of the DNR have been done, and you as a medical team, you start now at least careless in the way of giving at least even a total facial smile for them, for their patients, that most of the times, most of the family wishes they have a right to reverse the DNR status, and this is very important information you have to know about the patient. So while the patient is already code status changed to DNR, patient should receive and have been provided by all other manners of management apart from cardiopulmonary stations. May I stop here, Rehab, to give the rest of the discussion, and any questions will be later on will be answered.
Okay, thank you so much, Dr. Thank you so much for your nice presentation. And as I said earlier, that if anyone have any question or any point he want to clarify, he or she want to clarify more, please drop it in the chat, and we'll be more than happy to answer your questions later. So I think Dr. Ahmed, he managed to get in with us, and he's the next speaker. Dr. Ahmed, he's a senior PIC consultant, and he's currently working in Universal Hospital, Khartoum in Sudan. He is trained in UK, and he had more than 20 years experience in pediatric intensive care in UK and Middle East. And his comprehensive experience provided him to have the ability to establish 2 major tertiary hospitals. I mean, PICU intensive care in 2 major tertiary hospitals in Saudi Arabia. Since he came back home, he had a huge involvement in rehabilitation and functionalizing the PICU in Jafar ibn Auf Hospital, which is one of the leading tertiary hospital in Khartoum, the capital of Sudan. And his dream is to create a national program for PIC fellowship in Sudan in the future, inshallah. So welcome, Dr. Ahmed, and the floor is yours. Could you hear me, Dr. Ahmed? Dr. Ahmed? Dr. Ahmed, could you hear me or see me? Okay, I think still Dr. Ahmed is having problems with logging.
Perhaps, sorry, Dr. Ahmed has left, and I'm trying to contact him. So if you present Ben, and we'll get to Dr. Ahmed soon. Okay, thanks. Sorry for that.
Thank you so much. No, fine. So we're gonna shift to Dr. Ben Raffertty. He is a senior pediatric trainee, grade trainee ST6, and currently working in North Island in Royal Belfast Hospital for sick children. He really enjoyed communication challenges, conflict resolution, and also he's enjoying teaching within the MDT environment and discussion about ethical dilemmas and dealing with the difficult situations. He led a 3-day teaching course, Sunflower course, and it's really amazing course. I've seen the timetable and everything for that. So, and he's talking about, today we're going to talk about the care, end of life care and withdrawal care, and we're going to discuss with us how to deal with this sensitive issues in pediatric critical intensive care. Where you are really welcome, Ben, and the floor is yours now.
Thank you very much, Rehab. So I think I can share my screen.
Are you a host?
Oh, I can, yeah, I see it here.
Perfect.
Can you see that?
Yes.
Wait, is that better?
Yeah.
Okay. So hello, everybody. Yes, as Rehab was saying, my name is Ben. I'm one of the pediatric intensive care trainees currently based in Northern Ireland, and I am teaching at the British Sudanese Association here today because my wife is Sudanese, and that's why I've just sort of dropped in here. Haven't been forwarded a link a wee while ago about the KeepMeSafe course from my father-in-law. So that's a brief summary of what why I'm here and why I know about the course. So it's great to see all the work that Rehab and RWA are doing. So yes, I'm going to talk about end-of-life care in the UK. So I'm going to talk about how common it is, what is palliative care, some of the terminologies that we use in the UK. They're pretty much global, a lot of the terminologies, and Dr. Juma had mentioned a couple of these. The goals of palliative care, the legalities within the UK, which are maybe slightly different to some of the Middle East and North Africa. How to approach the subject of end-of-life care, how we tend to do that in our unit, the difficulties, and then very briefly on symptom relief. It's very difficult to try and fit all this into half an hour, but I'll give it a go. So what is end-of-life care? I think sometimes it's important how you say things as well as what you say. Sometimes it's usually more important of how you say things than what you say, but words are important. And I think it's important to the family as well, whenever you're talking about end-of-life care, that you don't say we want to withdraw care, because care should never be withdrawn, and care is never withdrawn. As long as the child is in your presence and is in the MDT's presence, you're going to care for them. So I think withdrawal of care is a misnomer, and we really shouldn't use it. We reorientate care and change the goalposts with regards to what we aim to achieve. So with end-of-life care, you want comfort surrounded by your family and friends in a very dignified environment, taking the opinions of the family on board, ensuring that those goals that are met, which are new goals, can be achieved to the best of their potential. But I think withdrawal of care can sometimes give the impression that you're abandoning the child and their family. So it's not something that I would recommend using. So in the UK, I could only find figures for England, but I suppose they'll have to do. Over 3,500 children in England die per year. So the children are classified as over the neonatal period, so greater than 28 days of life. But also over 2,000 neonates also die within any year within England. And as time is going on, more critically unwell children and neonates are dying in an intensive care setting as a proportion of the population. So a relatively much smaller portion of the adult population die in an ICU setting, whereas with regards to children, it's an ever-growing percentage. So it's very important that people who deal with acute situations and people in intensive care environments are able to understand the problems that families are having and able to treat children and their families with sensitivity and compassion and in an appropriate manner. So then what is palliative care? I suppose it's an active and total approach to care of children and young people with life-limiting and life-threatening conditions from the point of diagnosis throughout the child's life and also their death. And as Dr. Juma was mentioning, it embraces lots of different parts. So emotional, physical, social, and spiritual elements with regards to caring for the child in that time of their life. It focuses on enhancing the quality of life of the children and young people and the support for their family, and lets them know that there are other things that we can do, such as prevent distressing symptoms. Sometimes in the UK, you can provide families with respite care, so put the children into hospice care for maybe even just a couple of hours or a couple of days, just to give the family a breather through what could be a really difficult time. And then also being able to incorporate the palliative care team in order to make sure that the family realize that there's other facilities they can access as well outside the hospital setting, such as district care nursing and the hospice, as I've mentioned before. So I suppose in terms of terminology then, life-limiting conditions are those which there's no reasonable hope of cure for the child and the children will die. But some conditions, there's very progressive deterioration, such as Duchenne's muscular dystrophy, meaning that the child becomes increasingly dependent on the parents and carers. So there's a wide range from some, I suppose, metabolic disorders that can be sort of quite really quite life-limiting with a matter of weeks to months, whereas more chronic conditions such as Duchenne's muscular dystrophy and cystic fibrosis, for example, are in fact life-limiting conditions, but the children can live with a really good quality of life for many decades in some respects. So they can also be introduced to palliative care quite early and have it as part of their journey through healthcare. With regards to other things, other terminology, then there's life-threatening conditions. There are more acute situations in which the child falls severely unwell. It can be in the background of a life-limiting condition, but can also be in the background of a child who's also relatively well. I suppose the difficulty here is usually it takes a bit of time in order to involve palliative care. You have to be able to examine and investigate the child appropriately and come to an accurate prognosis before determining that it is indeed a life-threatening condition. And this is where the situation can get more difficult. So as mentioned before, that why do we use the palliative care team? It's about maximizing the quality of time that is left and allows families to decide on the important things within their control. So a lot of these circumstances are unimaginable, and the family believes that they have completely lost control. So even to regain some sense of control by what may be perceived as relatively small decisions can make a huge impact on the family and their ability to deal with a very difficult situation. So what's important? I think all deep down we know what's important. If you've ever had a relative that's died or pushed into life care, we all want the same thing, and it's really irregardless of cultural and societal boundaries. Everyone wants a pain-free death, which is comfortable, usually surrounded by your family. And it's important to tease these out from the family, and you need to ensure that you will try your best to keep them as pain-free as comfortable and possible. In a PICU setting, this can be used with a variety of infusions, such as continuing the morphine and midazolam, even in situations where care is reorientated, as this will help to maintain a pain-free and comfortable environment for the children. Involvement of the family coming into the intensive care unit is important, and other family members being allowed in the last couple of days or hours of life is very important. Was somewhat hampered with COVID restrictions, but now thankfully are lifting. But this is all a very important part of their care. And to be cared for in their particular setting, some children and families find that they actually do want to pass away in an intensive care setting or in a hospital setting at least, as they want to sort of separate their home life from this sort of tragic event. And there may be other children at home that they may want to protect from such a devastating impact. So the place of death, at least they will have died in a hospital setting away from their home environment. But again, every family is different, and it's important to explore this with them and which particular setting they would be most comfortable with. Also to have a plan. So families want to feel listened to, and that if certain instances arise, that there's a plan to deal with such things. This can be difficult if the families aren't accepting, but even for families that find it difficult to accept that their child is critically unwell or has a life-limiting condition, a plan is good. And even if it's small points, we can always build on that as time goes on. So why do we practice medicine in the first place? I suppose it's, as you can see there around the teddy bear, is to restore health, alleviate suffering, sustain life, and prevent disease. And there is a lot of similarities in this with palliative care, but I suppose restoring health and preventing disease is maybe less important, but alleviate suffering is just as important. And I suppose also to sustain life for as long as is appropriate. So we have to change the goalposts. And as I mentioned before, comfort is a big part of that. Alleviate suffering, and this is either physical suffering in terms of, nausea, pain, breathlessness, but also the psychological suffering of those around the child as well. Try to alleviate their concerns, and then move forward with some sort of plan for the family. I've heard a quote a couple of years ago, I can't remember where it was from, but I thought it was excellent. Especially coming to the end of life for even a young child, especially in a neonatal setting, instead of having like a life that's full of special moments, you want to achieve a lifetime within a few special moments. So they don't have their like a long life to achieve a great array of special occasions, but they have a couple of special moments that they can live as full a life as is achievable. And I think this is very important, especially for the families, that they'll look back and feel like even within that short period of time, they accomplished more than they ever thought would be possible. Again, compassion is key to be understood. Oops, somebody's dropped something. So compassion is key to be able to understand what the family are going through, and then to be able to promote that autonomy. So again, mentioning those small little changes that may not seem particularly significant from the outside, but to the family are essential, that they have some say in this otherwise uncontrollable situation. So then the legal issues in the UK. So even within the UK, there are slight variations, but there seems to be Scotland is sort of a little bit out on its own with a few respects, but it's pretty similar between England, Wales and Northern Ireland. So the legal issues really are the Children's Act of 2004, which states that the child's welfare is paramount and the parents have rights and duties to look after the child and make decisions on behalf of the child, especially if they're really under the age of 18, with a few caveats. But they must be in the best interest of the child. So I suppose parents have a right to make decisions for a child, but again, they must be in the best interest of the child or these can be overruled. Then you have the European Convention of Human Rights, which is involved about balancing the protection of life with also respecting the dignity of life as well. So this will state that everyone has the right to life. However, you also have the right to not be your life to be treated in a degrading manner, and you also have the right to freedom of expression and also freedom of culture and religious practice. So these are all very important whenever you consider end-of-life care, because this is exactly what we want. And then you have the Mental Capacity Act. So this is where it gets a little bit fuzzy. And capacity is in the UK is deemed most people will have automatic capacity over the age of 16. However, if you think there's issues with capacity, you will have to assess this. So be able to see if the young person is able to understand information, weigh up the pros and cons, and come to an informed decision on that basis. If you don't think they're able to do that, then they do not have capacity. And children are classed as under the age of 18 in the UK. They can agree to treatment, but they cannot refuse treatment in their best interest, even if they have capacity. And that's from a legal point of view. However, if there's any issues, so if a child, say, for example, there are children who have, say, cystic fibrosis, for example, who are 16 and 17, have had a very rocky course and now refuse treatment because they understand that they've been through a lot in their life and they don't really see the onward suffering as beneficial to their quality of life. So we have to respect that situation, but also seek legal advice, because legally that child doesn't have the legal right to deny treatment to themselves, as they are legally a child. However, you'd obviously be in conversation with the parents and legal advisors as well. So parental responsibility in the UK, I see that from Dr. Juma's talk, this is quite different. So the father really does not have automatic parental responsibility in the UK, the mother does. and the mother is always the first point of call. The father only has parental responsibility in the UK if he is named on the birth certificate. He does not have parental responsibility if he is not on the birth certificate. If the father is married to the mother at the time of birth, then he will have parental responsibility. So in most situations, the mother, well, in the vast majority of situations, the mother will have parental responsibility unless the child is adopted or is under some sort of social protection order and has shared parental responsibility with the trust overseeing the child's care. And in terms of parental responsibility, you need one parent to consent to medical treatment. Again, though, if there's a disagreement and the medical team feel that the parent's decision is wrong, they can be overruled by the medical team to treat the child in their best interest. And again, this can be resolved either locally or through the courts. And also in the case of withdrawing care, or well, I suppose that's a terminology I didn't want to use myself, but yes, the withdrawal of sort of medical treatments, it's a medical decision. The parents legally have no input with regards to that, but obviously it's a very important decision, and it's something that needs to be discussed with them. And if there is large disagreements, usually trusts and medical professionals tend to side with the parents in the interim, awaiting a court decision. And in the UK, the three different caveats of care, so the initiation of care, the withdrawal of care, of medical care I'm talking about, withdrawal of medical care, and the failure to even initiate care, they all have the same legal standing. So if you take medical care away from someone, it's the same as never having started it in the first place. So yeah, how to approach end-of-life care. You want a good working relationship with the family. Compassion and empathy are obviously key. You want an MDT approach. So this is not something to be done by one doctor in isolation. You want your nurses, your physios, your OTs to all have a say in the child's quality of life and their prognosis. And also within the subspecialties, say for example, neurology, you want them to sort of, on the best available medical evidence, to point you in the direction of the likely prognosis of the child. And each specialty must be clear of the likely outcomes and risks, and make the parents very much aware of that. And the parents need to feel listened to, and there needs to be honest and open discussions between the parents and the professionals involved. And in PICU in Belfast, we tend to have multidisciplinary meetings with the many different specialties involved with the child's care, PICU. We have a list of issues that the child has, and then some possible solutions with the caveats of the downsides of those, and then address what the parents' concerns and issues are, and come to a sort of mutual understanding about what is achievable and is best in the interests of their child. So then after that, you can have a plan going forward, but also be aware that plans can change. So even though you have an end-of-life care pathway, things can change. The child can suddenly deteriorate, the child can do a lot better than expected. And this needs to be flexible as well, and needs to be constantly revisited. And again, this is all about being open and honest with the parents, and be able to say at times that we don't know what's going to happen. We think this will likely happen, or there's such and such a chance of such a thing happening, but there's nothing certain. We can come into difficulties when families are less accepting of circumstances. And sometimes, if you're able to, the best thing to do is park a conversation and revisit it at a later date. This isn't always achievable, but in the vast majority of cases is. So that's something that can be considered. And as I mentioned before, conflicts are best or most likely to be avoided if everyone is open and honest with each other. So there's many different issues, such as you can have difficult situations, such as a previously well child, such as this case discussed initially, who suffers a hypoxic brain injury. it can be very difficult for the parents to accept that, as it's a huge impact on their life. Having a previously well child to having a child who will have profound disabilities if they do survive. There may be differing opinions with regards to the parents and grandparents with regards to what's best for the child. There can be unique situations in terms of children with chromosomal abnormalities that may not have an underlying diagnosis, of which the prognosis may be unknown. This can have its own challenges. Cultural beliefs is also can lead to issues, as many cultures sort of are quite protective of their children and find it very difficult to let go, even in dire circumstances. External influence from their local community can also have a big influence, and with the invention of social media, you can have alleged experts from all over the world giving families false hope, which really can be devastating to a family who's really grieving. And then, as we're quite au fait with in the UK, and I'm sure are across the world as well, media attention. Tragic stories and miracles will get you the most clicks and will sell you the most newspapers. However, we have to be wary that these are uncommon events and really are over dramatized. It is not real life, and is the exception, and we have to make people mindful of that. So I suppose with regards to the difficulties above, there are good and bad parts to these. It can highlight the issues with end-of-life care in children and the difficulties that the MDT face, but they're also very difficult. So the top tips for conflict resolution is, I suppose, to provide small amounts of information regularly, the chunk and check mnemonic. So it's about giving a chunk of information to the families and checking if they're able to understand it, especially in the very early stages. Families are really not going to be listening to what you're saying. They're going to be able to pick out maybe a couple of words of you chatting to them. And it's maybe better just to give them small amounts of information, what's important, and then leave, let them digest it, come back and see if they've understood.
Sorry, 5 minutes left for you, Ben.
Yeah, no problem. And then in the UK, then we are starting to have patient advice liaison teams, usually a specialist nurse that can sit down with the family during their time in PICU, and they can outline the problems that they've been having or the issues that they think that may need resolved or haven't really been grasped by the team, communicate this to the team as sort of like a communication middleman, which can be very useful, as you know, the nursing allied healthcare professionals and the doctors can be quite busy and don't have particular time to sit with the parents that patient advice liaison team may have. Again, involving the opinions of the MDT is very important in terms of prognosis and keeping the parents up to date in a timely manner. Things can change quickly, and if they feel like you're holding information from them, this will not be good. So as I mentioned before, open conversation is usually what's best, and we've talked about the MDT. If the parents have come across information that is maybe not known, you may want to seek a second opinion, either from similar specialties within your trust or consultants within that team, or look further afield at different hospitals and different trusts to see if their policies differ or if they can review the child's cases. It can be very useful to see if they will add anything else, because usually there's one or two things that they may be able to add, although it may not change the overall prognosis or management of the child in many circumstances. If things deteriorate further, mediation services may be used. Again, I think then the PALS, so the patient advice liaison service, is sort of taking the role of a mediation service. So a sort of outside body who's able to act as a communicator between the parents and then the MDT and PICU. And then if all else fails, the courts are there to decide what is in the child's best interest. So the courts in the UK, they don't have an absolute right to impose life, but they obviously are very pro-life. But if by the medical community it is deemed that the intervention is deemed to be futile, then the courts will rule on the favor of the medical team. So they will be looking at determinants such as if the intervention is likely to improve future life, if it is likely to be tolerable to the child, and the clinical considerations, if it's going to help the child survive the illness, and the pain and suffering caused from the intervention, and if the child will derive any pleasure from their current life. So if things get difficult, it's really for the courts to decide what is in the child's best interests. And then I'm not sure how far this has traveled sort of across the world, but within the UK, we've had the recent tragic story of Archie Battersby, who, quite similar to the case mentioned above, was a strangulation, severe hypoxic brain injury, and the case went to the Supreme Court, who then ruled that it was not in Archie's best interest to maintain artificial ventilation, as he had no chance of recovery. However, I suppose the parents, especially his mum and wider family, went through the grieving process in a very public manner. And I suppose there's a lot of questions that can be asked of the media about if this was appropriate. I suppose it was important to highlight the issues, and the mum was maybe just looking for answers. But unfortunately, I think it's maybe took away from her time that she had left with Archie. So it's important, I suppose, to maybe try and prevent these cases from escalating to that, because at the end of the day, I think it's a missed opportunity for Archie's mum to spend time with him. So as I mentioned before, and Dr. Juma had mentioned, end-of-life care plans can be useful. I suppose from a medical point of view, you want to see if CPR is appropriate. And again, this is a medical decision and may be discussed with other teams, and you may want a second opinion, especially if the parents disagree with that opinion. There is then issues about nutrition. Should the children get clinically assisted nutrition and hydration? And the UK's take on that is that if it is likely to prolong the death, that you are within your rights to withhold nutrition, but this should be liaised with the family. And again, if there's any issues, it should be taken through the courts. In terms of terminal gasping, this can be relieved by diamorphine and other strong opiates. However, they do not recommend the use of muscle relaxants in terminal gasping, as this will expedite the child's death due to decreased respiratory drive. And early involvement of palliative care and organ donation is also important, as especially with organ donation from such a tragic event, you may be able to somewhat ease the blow to the family, as they will be able to provide life to other children and other people in dire circumstances. It's important to learn from past events what worked and what can be improved, and also to inform other teams, so like the child's GP, that care has been reorientated. So there's a quick slide on pharmacology and end-of-life care. So things to think about are constipation, pain, anxiety, breathlessness, nausea, secretions. And this is really where the palliative team come into their own. It's about keeping the patient comfortable as possible. And there's excellent guidelines online from Short Lives for basic symptom control in paediatric palliative care. And they go through a wee formulary at the end. So I just thought I'd highlight some of the drugs that are commonly used in either PICU or in the palliative care setting in the hospice. And these can be given a variety of means, obviously either orally, IV, or subcutaneously in children where you feel that IV access isn't in the best interest of the child. And then onward, support for the families. You're looking for psychological input if needed. And there's some evidence that follow-up appointments may be useful within 1 to 2 months to allow the family and the community time to grieve. And then they'll be able to revisit some medical questions that may be outstanding and sort of draw a line under those with regards to the family's grieving process. You may want to provide genetic support in terms of neurodevelopmental disorders or metabolic diseases to ensure that the family are less likely to go through these situations again. But the most important thing is for, I suppose, family and community support, which is really up to the family about how much they wish to engage. So yeah, in essence, in conclusion really, the aim of palliative care is to keep the child's best interests at heart with regards to all decisions. And there's a couple of references. So a lot of this was taken from the Archives of Disease in Childhood, making decisions to limit treatment and life-limiting and life-threatening conditions in children. It's a very useful document and sort of short and succinct. And then, as mentioned before, Together for Short Lives also provide great guides in terms of palliative care and some pharmacological stuff around that. Thanks.
Thank you so much, Ben, for a really nice presentation. Thank you so much for this. And I think you promised us to do a workshop, the sunflower workshop in the future. Am I right?
What's that, sorry?
You promised us to do the sunflower workshop.
Yes, yeah, I'll get elements of that and share it with you, no problem, yeah.
Thank you so much. Thank you so much. So if you got any questions, guys, just please drop it in the chat. And the speaker, they were going to be more than happy to answer all your questions. I think our next speaker, Dr. Ahmed. Could you hear me, Dr. Ahmed?
Yes, I do. Thanks.
Perfect. Thank you so much. And Dr. Ahmed, as I said earlier, he's a senior PIC consultant and currently working in Universal Hospital in Khartoum, Sudan. He UK trained, and he got more than 20 years experience in pediatric intensive care unit in UK and Middle East. And he's been involved before in establishing 2 PICUs and 2 tertiary hospitals in Saudi Arabia. And he back home, I think 1 year ago, and he's starting rehabilitation and functionalizing the PICU in Jafar ibn Auf Hospital. And his dream is to be one of the people that are creating a national program for PICU fellowship in Sudan in the future, inshallah. So the floor is yours, Dr. Ahmed. And he's going to speak today about the obstacles faced him and his team in the managing the case Dr. Israa area she talked about. So you can start.
Thank you very much for giving me this chance to speak to you. And for reasons of telecommunication locally here and the net problem, I haven't been able to follow most of the talk, but at least say I have listened to and heard the Dr. Baha comprehensive talk for almost 2/3 of it, and the last speaker as well also in the later half of his speech. And yes, I believe Dr. Israa, she presented the case very nicely. And this is actually one of the challenges are too many, but I would like to start with the fact that the time factor where this patient has been delayed a lot, because probably we can say that the chances might have been better if she presented earlier than they did. And this is because of some logistic, some financial problems. And unfortunately, our pediatric intensive care and pediatric critical care services in Sudan needs a lot of work to bring them back to a better situation. And I have to say that Jafar ibn Auf is one of the oldest pediatric hospital in the region, if not in the continent. It's been starting early on, and it's been well equipped, and it is well known as a tertiary referral center. But unfortunately, it is now suffering from so many problems and obstacles. We hope that this can be improved. Yes, we have been here, me and myself and a number of my colleagues who are returning to home. We are trying to create better health services for our children of Sudan, and mainly the critical care, which is really needs a lot of work. However, the unfortunate case, which ended in the child dying because of a strange event of strangulation while she was playing. And as I said, she needed a long time, which if she presented earlier, the outcome might have been better, but anyhow, that was her fate, as we say. And I think we have done all what we could. We have been supporting the parents I used to sit with them on daily basis after the round and updating them about the progress of their child. And when we have reached the point that the child is not making it, we had to do the brain stem death test, which I have to say that they are relatively not well known and developed in the pediatric hospitals. I have been to, maybe 2 or 3 of them. But anyhow, we have done it in the proper way according to the international guidelines. And that has been a good teaching and training point for my crew and my colleagues here, because probably most of them, that was their first time to practice this sort of testing the brain stem function. And after we have made it certain that the child brain death has occurred, the question was what to do then. And for me, that was not a new thing, and we have automatically put her on sorry, I'm trying to, but it tells me that you cannot start your video because the host has disabled it. So it is from your side. Okay. Please enable it, yeah.
Okay, leave it for me, thank you.
Okay. Yes, so that was done in the proper way according to the guidelines. And then the question is always, after you have proved that it is a brain death, what you should do. And then this will lead us to the other topic, which Dr. Baha and the last speaker has covered very well. And then we have to put her in DNR. And as I said, there is no national policy for DNR here in the country, as I came to know. And obviously, our hospital is a new hospital, newly started, operated. And our PICU especially is also a newly opened PICU. And then we had to use our best practice before, because I have practiced this DNR in several other countries. And then we have started the DNR, first of all, by obtaining the approval and signature of 3 pediatric consultants who have been involved in the care of this child. And one of them is myself, and the other one, my colleague, neonatologist consultant, who has also been involved with us. And the third one was the specialists who have been also involved in the care of the child. And we all decided, we specified the time and the date, and we have all signed that we grant that poor child the status of DNR. And then I sat with the parents, and I have explained it fully, that what DNR means and why we are deciding this, and that we are just informing them. So the DNR is for as a clinical or decision made by the medical team, but the parents, they have to be informed, but there is no consent. It's not up to them to refuse or accept. This is why we had to be very careful in deciding the brain death according to the full criteria, the 8 criteria of the test, plus also because one criteria of the first apnea test has not been conclusive. So we had to do an EEG, which has confirmed the absence of electrical activity of the brain as reported by an eminent pediatric neurologist. So we granted the status of the DNR and explained that to the family fully, and they accept that painfully. The mother was very tearful, of course, that is a natural reaction, but both of them, they accepted that. And here comes the importance of the cultural and the religious part of the story. So from all what have been discussed during this meeting, the cultural issue, the religious issue, the social issue is a very important part of the whole thing. And this is why, yes, I think everybody can see me now. I have very white beard and mustache. Okay, right.
Yes, you can see.
Yes, good. That is good. So that is what has been going on. So let me now bring the things to narrow it, because I think the time factor and as an important thing now, the cultural, the social, and the ethical, and the medical legal, and the legislative, all these factors are very important. So I will try, and I'm calling for a national health service policy for children. This should be done, which to my best knowledge now, it is not well known or well established. So we need to establish this, and this is, before this, we need Child Right Act. This is not, it is as a general international Child Act, is a Right Act, it is there, but we need a Sudanese National Children Act. And based on this, then we need to formulate a DNR status, whatever you call it, whether DNR or end of life, all these things. But we all know now what does DNR or DNR means. Okay, what does it mean? So from here, we need a national health policy for children to include this issue.
Dr. Ahmed, are you still with us? I think there is a problem. Dr. Ahmed, he left the session. Dr. Ahmed, are you logged in back?
He's not here, Rehab.
Okay. So I'm gonna go through the question in the chat. Yes, while he's trying to log in. Okay, so I've got here a question from our colleague Abdullah Tayyib. Hi, PSAP-CH group. Thanks for your great effort. Why these activities not under the SMSB PEDS section umbrella, and especially with the recent matter of the pediatric training exams issues in Sudan. So thank you very much, Dr. Abdullah, for your question. So basically, I think when we came in, before we come to Sudan to do the Keep Me Safe course, we get in touch with a Dr. Abdulmunem Hamid. He's the head of the Specialized Medical Board in Sudan. And we have also discussions with the other PIC consultants in Sudan, Dr. Ahmed AbuSebah and Dr. Yaqub and other PIC consultants. And they know about the project and our interest in involving other people to train more staff in Sudan. And we shared with them initially, we're going to start with the nursing staff and the junior.
I'm sorry. I'm sorry, because a land call has come in and it cuts me off the internet.
Okay, that's fine. So I've just started going through the chat, but you can resume your presentation, your talk, and then I'm gonna go again back to this.
Okay, right.
Thank you.
So just let me try to put it in point.
Could you hear us, Dr. Ahmed? Dr. Ahmed? I think we lost him again. Yeah, so I'm going to just continue until he...
Hello, yes, sorry again, I don't know what is happening, because you know that the net here is very...
Okay, yeah, that's fine. We can hear you now very well. You can.
Yeah, okay, so let's go back that we need legislation and in the form of Sudan Child Act, Child Right Act, number one. Number two, we have to set up a national DNR policy as a part of a national child health policies. And this is number two. And number three, we have to help through our SAP and our organizations and these things to improve the critical care and in Sudan, in the different hospitals. And I can see now there are a number of new critical care, pediatric critical care units being opened and being established. So we have to provide them and to support them with the guidelines, with the literature, and if possible to make links with different international organizations so that they can benefit from this. And also we have to look into training programs for the medical and nursing pediatric critical care services as well. And even due to this many interruption, I found my brain now is shattered and then going everywhere, and I lost my concentration on the subject. But what I wanted really to say that we really, from what the valuable talk has been given, speech by the different speakers, but Sudan has a very specialized, of course, sort of cultural, legal, and legislative things, and we have to consider all these together. I have to say that this is not the first case. Before that, a few months, 2-3 months, we had also a child who has been very sick, and who also we have proved that she is older, much older, that she was at that time brain dead, and then we had to put her on DNR. And then the question which I want to raise is that what after DNR? There are here 3 or 2 things. One of them, the withdrawal of care, and then the withholding of care. Withholding of care will be decided early on from the ER or at the admission of the patient to the critical or to the PICU. That is the first thing. And this is a rather challenging and difficult. And the other part is withdrawal of care. So the child is already intubated and ventilated and receiving maximum care in the form of medicines or any other sort of supportive vehicles. So definitely, I personally, and this is my own personal idea, is that, or opinion, that no child, with whatever his condition after DNR, should be taken off the machine. And because still the problem of this, you cannot be 100% sure of. And I think the last speaker pointed out that because in Saudi Arabia, we used to review the DNR cases on regular basis. And within the policy, by the way, the Saudi has got a national policy and guidelines for DNR, including definitions since 2013. And it is well established, as I said, there are the forms and everything. So this is why withdrawing the care, I don't agree on it for any, whatever the reason might be. And then but what you will do, yes, you will not add new, and as DNR say, do not actively or do not actually attempt resuscitation. So you keep him as he is. Still, I used to wean if the child is overventilating, although that is not a usual physiological thing, because especially if he's brain dead. But if he's not brain dead, okay, and most of them, they went into final things, and then here it is the futility rather than anything else of what you do. If it's a futile thing, then probably you shouldn't do. But I never in my practice, which goes for more than 25 years now, I've never withdrawn care from any child, even if he is a DNR. And some of them, they stayed for months. But believing that we have, according to the policy, every 1 month, every 30 days, we have to review the case again and renew the DNR status, or either you revoke it or you continue with the DNR. And it happened that we discharged some of them to the ward where they stay there. And even if they go home, those who are in the vegetative status, we don't say they shouldn't come back to us, but we don't accept them easily onto the PICU again if they need future admission. So these are more of philosophical, ethical, and religious points which really need to be addressed, especially in the areas of the world where these cultural sort of things are prevailing. I'm really grateful for giving me this chance. Although, as I said, the problem of the net and the telecommunication here in Sudan deprived me from following or putting the things which are really
5 minutes left, Dr. Ahmed.
Okay, thank you very much. I have already almost concluded and finished my talk, and thanks a lot.
All right, thank you so much, Dr. Ahmed, for your nice talk. And I think we can go quickly to the chat and answer the questions. I think before Dr. Ahmed rejoined us again, I've started answering the Dr. Abdullah Tayyib question. So as I said earlier, Dr. Abdullah, we had a connection with the Sudanese Medical Board head, Dr. Abdul Munaim Hamid, and we had some connection with the PIC consultant resident now in Sudan. And I think in the future, we are planning to accommodate a lot of people that they're interested in a PICU and the pediatric emergency in Sudan. And the plan is just to try to help the trainees, help the junior doctors in Sudan. And we will really be grateful if you can join us. I put in the chat the WhatsApp group for anyone who's interested in pediatric critical care and emergency. And together we can do definitely a great effort to help the people in Sudan. I hope that I addressed your question. The other question here from Dr. Maha Azhari. She's saying that thanks for the lovely presentation. What what if the co-patient refused the medical decision of DNR to a PICU patient, putting in mind we have an extremely limited PICU resources in Sudan? So Dr. Baha, you talked about the DNR. Are you happy to answer that question?
Thank you again for the questions, Dr. Maha. Actually, as we mentioned at the end of my talk about the unconflict status. So your scenario is mentioning that the co-patients, and if I understand well, that it should be, this is the one, the legal guardian should be defined from the beginning, who's I'm talking with. Is this the one who is going to take the legal guardian in front of the rules and laws of the country when the situation is raised up to the ethical committees or to the laws, or then at that point, as we mentioned earlier, this is a medical decisions. The don't attempt resuscitations is purely medical decisions. But at the point that, or as your policy, if the acceptance is not going to be run or change the code status by the legal guardian, we should follow this. The decision of non-acceptance means, yeah, me as a medical team, I know or I understand well, my decision is this patient is eligible for an accord status of don't attempt resuscitation. At the same point, when you address this decision to the co-patient who is supposed to be the legal representative for the family to his child according to the rules with documentations. If he's not the one who's have a legal guardian's representative from the family, he's not supposed to be the one who can make or change your decision. However, this is not going to be practically well done unless you have your own policy, which should be addressed from the beginning to the family if this patient is going to have this sequencing. So without a clear policy from your side, this is not going to be applicable, and then you have to ask one question: are you the right person to refuse or not?
Thank you, Dr. Baha, for your explanation. So Dr. Abdullah also, he got a question earlier that can you go back and illustrate more about the difficulties and challenges in the case? So I think Dr. Ahmed, he talked about the difficulties and challenges, and he also talked about when they've decided to do the DNR. I hope that answered your question, Dr. Abdullah. If not, please drop in the chat that if you have any more questions or you want to ask specifically on something. Ben, he is asking, in the first case, was there a reason that peripheral adrenaline was not used in a fluid resistant shock? And he got another question, how long was it until a central line was obtained? Dr. AbuSebah, are you still here, Dr. Ahmed? Dr. Ahmed?
Yeah. Yes, sorry, yes. But I can't remember here when was the question, when was the central line placed, but I believe it has been placed within the same day or the following day after things have started to deteriorate. So that is the thing. And at the same time, really, I can't remember the details. Probably Dr. Israa might have the details of this when and the timing and these things. This is the question of peripheral adrenaline. Probably, what do you mean by peripheral adrenaline? Yani giving the adrenaline earlier on. Yes. She's been resuscitated, fluid resuscitated, expanding her blood volume and circulation, and that has been done peripherally early on. Actually, even the hospital, referring hospital, I believe has done some of that, giving fluid boluses, and this is a common practice that whenever a child comes to the ER in a state of shock, they have in their guideline that they will start expanding the vascular volume by giving a set of fluids, normal saline, until a certain volume. After that, if intubated, then they will continue expanding if needed. So I believe that she's been recovered from the shock state, and then that has been done within a reasonable period of time. Yes.
Hi. Central line inserted immediately at the ER level when patient came to us.
Oh, great. And so, yeah, I was just wondering in terms, because it said she had 40 mils per kilo of fluid, but then her blood pressure was still 56 systolic. I was wondering if there was inotropes then started after that, or further fluid, or how that was managed, or did she just remain hypotensive for 24 hours, or?
No, actually, we have here in our guidelines and our practice, daily practice, that in such cases, we aim at the 50th centile of the systolic MAP, and mainly the MAP, actually, because the perfusion of all vital organs depend on the MAP. So we have this target. Our target will be is to reach the 50th centile of the mean arterial blood pressure, and of course the systolic. By definition. And then once we reach that, we reach it by either giving the fluid if we feel that the child is still fluid deficient, or by inotropes, whether 1 or 2 or even 0 inotropes. So we have always a targeted sort of management plan. Yes, hello?
Thanks. Yeah.
Hello? Yeah.
Yes, we can hear you, Ben.
Yes. Okay. Yeah. Yes. That's as I said here in our practice, daily practice, that we target certain vital signs, especially for the blood pressure in the hypotensive shocked children and similar. We target the 50th centile, as I said. We use the centile charts here very widely for the blood pressure, the systolic, diastolic, and even for the MAP. And we care about the MAP more, especially those with brain problem, or they are unconscious or coma, because we have to keep the mean airway pressure that at a level that will ensure cerebral perfusion pressure. And whether we need to do that by giving boluses or expanding the vascular volume, and by adding also inotropes, whether 1 or 2 or even 3. Sometimes we reach that. So our target is always to have, among other vital signs, is to have the mean arterial blood pressure at the 50th centile, according to the child age, weight, and the gender even. Yes, we have these specific centile charts of the CDC for the blood pressure. Yes.
Okay. Thank you so much, Dr. Ahmed, for your answer. Is there any other questions, guys? I can't see any in the chat. So if you have any further questions, just please put in the chat. I've just put the barcode for the KeepMeSafe WhatsApp group, so you can receive all the our advertise for the future workshops and CBDs, and update about the APLS and conferences and anything is relating to the pediatric critical care.
Hi, thanks, Rahab. I think there is hello, can you hear me?
Yes, we can hear you, yeah, Roa.
Yeah, I think there's a direct message came to my chat box from Dr. Abdullah Tayyib. Dr. Abdullah, I think you can just unmute yourself and speak about your comment and your questions, because it came direct to me, so nobody can see that.
Assalamu alaikum. Is my voice clear?
Yes, we can hear you.
Yeah. Thank you so much for this session. I really enjoyed. Thank you, the UK group, and Dr. Baha, as usual, and Dr. Ben from UK also, and Dr. AbuSebah from Sudan. Thank you for initiating this important topic and important work. in the ICU, pediatric ICU progression in Sudan, which is still crawling and starting to stand up right now by the effort of these nice people. I have few comments as being pediatric intensivist, pediatric cardiologist, and cardiac intensivist for years. Because I'm facing these scenarios and these dilemmas on almost daily basis, especially our group of patients who's significant cardiac patient or with severe congenital anomalies, who are facing this dilemma pre-operative and post-operatively. In Sudan, the situation is different, as we know, but I have 2 or 3 comments as this work is starting there by your leads. What I have few suggestions. First of all, should we involve the pediatric training committee in Sudan to involve the ethical aspect of training in Sudan? Because what we are facing now in Sudan is a big, large ethical dilemmas and ethical issues, which is propagated in the media. Sorry. There is sound interference.
Sorry, there is a lot of noises in the background, Dr. Abdullah. Okay. Yes, we can hear you now. Yeah, you can continue.
Yes, that is not from my side. I'm clear here. Okay, so what I mean that, what I stated that, should we involve the Directory of Pediatric Training in Sudan to create a clear lines of ethical teaching to pediatric trainee, especially at one stage they will face these dilemmas in their training about resuscitation, DNR, withdrawal of care, withholding of care. This is daily basis situation which everyone can face. This is the first comment from my side. So to direct or to ask Directorate of Pediatric Training Sudan to make a clear teaching to this aspect. The second one is to involve the religious committee, the religious affairs in Sudan, which is Majlis al-Iftah al-Shar'i in Sudan, about making clear guidelines. This can be led and created by Dr. AbuSebah. I think he's leading the ICU work in Sudan now. And we can help in that, Dr. Baha, some bunch of pediatric intensivists outside to make a clear guidelines, but we cannot ignore the religious affairs in Sudan. Any DNR status or DNR policy should be accepted by the religious affair in the country. So here in Saudi Arabia, we are obligated to follow Majlis al-Iftah al-Shar'i in Saudi Arabia. Even one case I directed, called them of withdrawal of care. And I think this should be also considered, if you agree with me, Dr. AbuSebah. The third thing that I want to highlight is the communication. So teaching communication is more important than teaching ICU care. I think to communicate with the family in a critical situation of their child is an essential thing. If we miss the communication and we concentrate only with the patient condition and patient management, then we miss a large part of this management, and then we'll be in a trouble later. If we didn't communicate well in every stage, exploring and putting this family on the same page with us, then we'll face a big trouble explaining and providing our plan of care to this patient. I think this is a big work, but it's starting now. And I think everyone should share doing this work with this good team. And we, all of us outside, inside Sudan, we are ready to help and to share this work. Thank you so much.
Thank you so much, Dr. Abdullah, about your questions and your feedback. So regarding the communication with the Sudan Medical Board and start giving training for the trainees, pediatric trainees, I mean, definitely this is something we're working at the moment. And in the future, as I said, that they can join the WhatsApp group and we can share, they can share their ideas and the thing that they want us to do, and we're more than happy to help them in this. I will leave the answer. I think Dr. Ahmed, you did answer about the ethical dilemmas and religious problems in Sudan, that about the DNR and withdrawal of care in end-of-life care. I think Dr. Ahmed, if he's still around, you can answer his question. Dr. Ahmed? Could you hear us, Dr. Ahmed? Are you still here? I don't think he can hear us, but I think he talked about we have a problems in like a guidelines and protocols in Sudan to tell us what we need to do and what shouldn't do. The other thing is you talked about the communication, and believe me that they're dealing with these kind of scenarios and situation in real life, even here in UK as a trainee, is really difficult. And it's a difficult scenario to tell the parent that this child is gonna die, and we are thinking about end-of-life care or withdrawal. But I think as a KeepMeSafe project, we'll put this in consideration, and we try to arrange in the future a workshop about the end-of-life care and how we can improve our communication skills and how we can try to deal with these difficult scenarios. And if you join the WhatsApp group, definitely you will gonna see that we're gonna announce for this in the future. I hope that I answer your questions. I think we've got a couple of questions here. So
can you send the WhatsApp group number to us, please, in there, because we couldn't join from the link.
Okay. Yeah, I can put it again in the chat, and you can just go and join there. Okay, that's fine. Thank you.
Thank you.
Dr. Safa, some parents have actually requested so many times to discontinue the CPR. They can't bear watching the team pressing on the baby's chest. What should we do? I think again, this is Baha.
Yeah. Actually, this is already have been studied, I think, in as a literature review from Canada point of view, to let the family attending the CPR for their kids. Actually, the outcome of that, some of them they completely in the same favor of this family who are refusing to continue while the medical team pressing the chest of their kids. Some of them they asking for more stuff. Why no more stuff to be beside when the kids they get sick, because only 2 staff doing this CPR, it will be too much. So it's a matter of concern. And then here again and again, you have to have a clear policy for this. The decision of stop CPR or put the patient on DNR status is purely medical decision. It will never be co-founded by a president of the families or president of any other bar family, unless this is my decision. My decision as a treating team is not going to get benefit from this CPR. That's why the best situation for our Sudan, in case in the absence of this all rules or all this policy, to do what we call it the advanced care planning. This means to ensure that your patients is receiving the medical care consistent with the values and goal and preference during their serious and chronic and acute life-threatening issues. So this will not come unless we do this kind of advanced care planning. We are not used to educate our patients and publics about this scenarios and situation. And as Abdullah mentioned, we have to educate also the healthcare professional about these scenarios and teach him how to communicate. And the clear policy from the station committee. I do believe in Sudan there is a station committee held by the medical councils. And this is to clearly mentions in their policies on each hospital when to stop and to start CPR. So I'll not leave it to the family because emotion is they don't want to like this. Is it the right things or the wrong things? And then you have to collect the data. How much this such a patient we do receive it, especially with this limitation of resources we do have it in Sudan. So again, end of life care is purely medical decisions, but it need to be communicated, understanding with the family. According to your local policy, the acceptance should be from the legal guardian of the patient or the patient itself if he have his own autonomy. So we never look for emotion. We not look for for other aspect unless this is my right decisions as a physician or as a professional towards my patient. I hope I can answer her the question of Dr. Safa.
Thank you so much, Baha. Ben, do you have any comments, and what's your idea about that question Safa, she asked about? Are you still with us, Ben? Yeah.
Yeah, I'm sorry. So yeah, I totally agree with Dr. Juma. It's not up to the parents whether they believe that medical treatment should continue or not. If the parents get suitably distressed during a resuscitation that you think may bring the child back, you need to assign a member of staff to politely escort the parents out of the resuscitation room, as it may hinder successful resuscitation. You need to always act in the child's best interests, and in that situation, if you believe CPR may return spontaneous circulation and the parents are hindering medical therapy, then they need to be removed in a sensitive manner, obviously. But yeah, medical decisions are for medics, and obviously the parents' opinions and values are very important. But it is not up to the parents to make medical decisions, and to make them feel as if they are is unfair on the parents. That is not their responsibility. Their responsibility is to look after their child. It's our responsibility to give the medical advice and make medical decisions on behalf of the child. And it's unfair for it. Well, it's totally irresponsible to ask the parents to do that, but it's really unfair to even give the impression that the parents have to do that, because obviously a parent will say, I want everything done for my child, and that's what you hear in PICU most often, and that's a totally natural thing to say. But I think the way we phrase things, a consultant that I work with, she's like, absolutely, we will do everything for your child that will work. And I think that's important. We will not do things for your child that won't work, because that's not fair, and leads to very undignified deaths. So yeah, it's important to sort of ascertain that we will do everything that will work, but if it won't work, unfortunately, it's not in the child's best interests to do that. I think it's important to make those differentials.
Thank you so much, Ben. Do you have any other further questions, guys? If you can just put in the chat. And well, as I said that earlier, that I'm going to put again join the WhatsApp group, and also you can go through the PSAP to see what the course, the KeepMeSafe course, the futures and ideas and activities and what's all going to happen next. If there is any further questions, thank you so much today for joining us, and I hope that you enjoyed that session. And I would thank again our speaker today. Thank you, Ben. Thank you, Baha. Thank you, Ahmed, for a nice talk, and hopefully we're going to see you in the future.
Thank you.
Thank you.
Thank you.
Thank you.